ADHIKARI. She is from Tilaganga Eye Institute, Nepal. She's from the city Kathmandu, and she's going to speak. I'm going to forward it for you.
Thank you so much, Dr. Ramesh and the organizing team for this invitation. I will show. Okay, so in the next few minutes, 1 or 2 minutes, I will show 3 clips of the pediatric cataract surgery videos, which I will just explain. This is the first one in which I'm showing without using the pupillary stretch, we can manage the pediatric cataract surgery in a small pupil. This is just an intracameral injections, which you can just ask from your anesthetic colleague nearby and then put into that. And then this is the another one. This is the inflammatory cataract. Sometimes even in the inflammatory cataract, if you break the posterior synechia, then it gets nicely dilated, and then you can do whatever you want to do, like membranectomy and then inserting the IOLs and all those things. This is the second video. And in third video, this is a very difficult to dilate pupil, and then but the cataract was only in the center, that was the calcified plaque. And with the help of vitrectomy cutter, actually in almost all the cases with the help of the vitrectomy cutter and with the small help of the intraocular scissors, you can just take out the part of the cataract, and then remaining you can just do the vitrectomy. So this way you can manage without dilating the pupil. This is the first video. And then now the second one. Sometimes difficult situations, different subluxations in the two eye. One eye had an anterior subluxation and the other eye had an posterior subluxation. So in anterior subluxation, you will not have very good capsule, and then iris fixating lens is also difficult because all iris has atrophied. And this is the posterior subluxation lens. It's a very large subluxation. So I did not put any CTR and I did not put any IOL in this case, because in the other eye, the child had an anterior subluxation. So sometimes it is difficult to decide which eye, what to do in these cases. And it's always better to, if you have these type of situations, instead of doing all the things, it's always better to leave the child FA kick for a while, and then when the child grows up, then we can think of scleral fixation IOL, because we don't put scleral fixation IOL before 10, 11 years old. So that is how we can manage these cataracts in the severe subluxation. This was the anterior subluxated case, and with the vitrectomy cutter, it's very easy to do everything. And the third video that I'm going to show is the difficult morphology. Sometimes whenever we get into these, like there is a posterior lenticonus and then large posterior subcapsular defect was there. In these situations also you can manage everything with nicely with the bimanual vitrectomy, and since there is already a large defect, and if we have to put a lens in the sulcus, this is our customized lens that is produced in our own intraocular lens laboratory, and this is a one piece but has a 4 limbs. So this is the lens that we put in sulcus. Otherwise we can put other 3 pieces lenses also. And this is again the second difficult to deal cataract with the morphological cataract, and then it also has a large posterior subcapsular defect. And if you are using the bimanual vitrectomy all the time, then whenever in this type of situations the vitreous comes in between very frequently, and you have to switch between the vitrectomy and the aspiration. So in these situations I only use bimanual vitrectomy cutter in most of the cataract surgeries in this type of situations. So I think these are the 3 videos that I wanted to show. Thank you so much. And
Thank you, Srijana, for these nice videos. So when do you use pupil dilators in terms of iris hooks or anything? Because what is the medicine you use it? Intracameral? Okay. So
it's a diluted adrenaline that I use, and then most of the time, almost all the time, I mean, I try not to use a pupillary stretch as much as possible. So sometimes it's very difficult, but you can judge, like if you don't need, like in the third one, there was only the small calcified area in the anterior part, and there was nothing. All the things were already absorbed. In those situations also, with the help of forceps and the vitrectomy cutter, I could manage that. And since that the child was a very infant and I was not putting intraocular lenses, in those situations, it's okay if even if you don't put pupil stress, you can manage very well.
Yeah, I think in patients with the severe posterior synechia, especially in rubella syndrome and posterior uveitic or anterior uveitic patients, probably you'll have to still use it.
Yes.
And also now, instead of using diluted adrenaline, the phenocaine, the epinephrine is available in the market, which you can inject intracamerally, so that really helps.
Yes.
Second suggestion I had was in lensectomies.
Yes.
You can also use sometimes the anterior chamber maintainer, so that it keeps your chamber very deep, and you can use aspiration or vitrector. That way it can really help.
Yes.
Any questions
I
from
use
anyone?
bimanual vitrectomy, IA irrigation and the aspiration. That's why it becomes easier. Yes.
Sorry, if you have a question, just come to the microphone. That's fine. But just say who you are and where you're from, please.
I am Dr. Sudhir Singh. I'm practicing pediatric ophthalmology in 1998, and I've developed this Quint Master software of this. This is my little process. So my experience is that we should not put single lens in the sulcus. It should be either 3-piece or like PMMA lens. So in our part of world, we have put small SICS with the PMMA lenses. They are more stable because foldable lens of single piece are the unstable lens, but you are having the 4 haptics.
Yes, that is 4 haptic. That is made from our own lab. And then in situations like sometimes in pediatric cataract and sometimes in adult cataracts, whenever there is PCR, and then it's difficult to put IOL. In those situations also, we have been using these lenses for many years.
And number two is while you are doing the vitrectomy, your cutter movement should not be jerky. It should be very smooth. It should be keep in the center. It should be when you are just because the vitreous base is around us. So later on we may have the retinal detachment because in pediatric ophthalmology. So third, just in this, when did you assess for the glaucoma, like pressure checkup, all your pediatric aphakic patients?
Pediatric
What is your protocol?
Yeah, we do UA. I mean, every 6 months or so, depending on how at the risk of the child has with glaucoma. In normal, regular cataract without any associated anomalies and complications, then we do UA every year. So it's difficult to put on the child on the UA, but in like other situations where there is other associated anti-segment anomalies and then the high chance of glaucoma, then we have to put the child on UA for every 6 months or so.
Virender, you can go ahead.
Yeah, we'll do one more question.
One more.
Sorry, we'll hold. I promise you we'll get to questions at the end. Go ahead.
Quickly, just as a follow-up to the 4-piece, 4 haptic single-piece IOL, how long has been your follow-up and any issues you have?
Yes, we have been using that for last 11 years, and it's a very good. There is till now there is no, I mean, decentration or
No
anything.
excessive inflammation.
Yes.